tough group to follow here, but thanks for sticking around for me. Again, I'm Lisa Ishii, and I'm talking about telangiectasia, so let's get started. I have no disclosures. Okay, so this person walks in your room, and if you're anything like me, you're all excited to treat them, but some of you guys might be looking at this leg and saying, oh boy, not again. But what makes lower extremity telangiectasias unique? So a few things. So first of all, these vessels tend to be larger in diameter. They're situated a little bit deeper into the skin. And sometimes the hemoglobin is not fully saturated. So sometimes you see a little bit more of like a purpley blue hue as opposed to that bright red you might see on the face. And especially with stasis changes, the vessel wall can actually be thickened. So when you're reaching for a laser to treat these things, you got to take all that into consideration. So, telangiectasia diameter and depth. If you don't select the laser that's penetrating the entire diameter of that vessel and you leave some of those endothelial cells behind, these things are going to come back, so you just got to be careful. And I think one of the most important things is you got to take a step back and look and say, okay, are there any feeder reticular veins? Because if they are, and you're just treating that telangiectasia on top, you're kind of just like slapping a Band-Aid over the bigger issue, and you're not going to give the patient a good treatment. And, not always, but is it red or purple? If you're treating a purple vessel and it's not really going away, you might say, okay, I might reach for something that maybe gets deoxyhemoglobin a little bit better than oxyhemoglobin. Okay, so KTP and frequency double ND YAG 532 nanometer laser, great case by Dr. Goldman. You got to remember with 532 nanometers, they're really superficial. So it's about 0.75 millimeters into the dermis. So when you're selecting for this laser, you got to remember to select a vessel that's really, really small in caliber and really superficial to the skin, because otherwise you're not going to get a good treatment. The typical endpoint, you might see some blanching of the skin, you might see disappearance of that vessel, and oftentimes you'll see coagulation of that vessel, so a little bit of darkening. Pulse dye laser, 595 nanometers. So because of the wavelength, you can get a little bit deeper. We saw that illustrated in the great presentations before. So you can get a little bit larger vessels, and typically the endpoint is, again, either disappearance of that vessel, but in my experience, more commonly, you'll see coagulation of that vessel, so a little bit of darkening. That purple gets a little bit more purple. With both KTP and pulse dye laser, you might see some epidermal sloughing, and if you do, you have to be careful because you might get hyperpigmentation or hypopigmentation. So this patient was really, really lucky where the hypopigmentation actually resolved by about a year or so, but I mean, look, it's pretty noticeable, and unfortunately it took a full year, so you guys just got to counsel your patients accordingly. This is long pulse ND YAG, 1064 nanometers, and you can see, you're able to target a little bit larger vessels, so venulectasias, and a little bit kind of deeper into the skin, but the biggest thing I want to point out here is take a step back and look, because those ill-defined reticular veins in the background are largely unaffected, and that's because even with that long pulse ND YAG, you can't target these. So again, if a patient like this walks in your office and you target the superficial stuff, you got to kind of remind them that these things might come back or you might make new ones. And of course, I won't belabor this because this was already in Dr. Goldman's slide, but it's a great case. Essential telangiectasia of the leg, had sclerotherapy before with no improvement, so IPL with 570 nanometer filter was tried, and you can see these fabulous results here. But again, you got to be careful because with IPL, sometimes it can take away that pigment. So you can see this hypopigmentation. And again, it came back 1.5 years later, but it's kind of a long time. Okay. So I know it's a laser conference, but I feel like I can't talk about lower extremity veins without talking about sclerotherapy. So I guess this is my dual part of it. Okay, so you guys got to remember that sclerotherapy is still the gold standard for lower leg vein treatment, including these telangiectasias. And I trained under Dr. Goldman, so I do foam sclerotherapy. So typically for the reticular veins or the larger venulectasias, I use 1 cc of 0.5% polydocanol or 0.5% sodium tetradecyl sulfate, and I foam it with room air. Typically, I limit myself to a maximum of 24 cc of room air, which means that if a patient has a lot of vessels on both legs, I typically split the treatment into 2 different sessions. For the smaller venulectasias and telangiectasias, I typically use an unfoamed solution of detergent or 72% glycerin. So I went into the literature for you guys to look for comparisons head-to-head looking at lasers versus sclerotherapy, and I found 2 big studies, big-ish studies, and they both looked at long pulse ND YAG. So this is a great study by Tina Alster and colleagues, which compared sclerotherapy with sodium tetradecyl 0.25% unfoamed solution, 2 treatments with laser, and it they found that the improvement scores were consistently greater for sclero at all follow-up periods. They also noted early vessel clearance with sclero, and unfortunately, there was PIH noted in 2 patients as a known side effect. Here's another study similar, again looking at long pulse and EAG, but this time comparing it to 75% glucose solution, just one treatment. And this group found that both laser and sclerotherapy led to a significant clinical improvement of all treated sites. And similarly to Dr. Ulster's study, vessel clearance was faster with sclerotherapy. The pain level, though, was significantly higher in the laser group, and maybe related to that, the patient satisfaction was actually higher in the sclerotherapy group. Okay, so when that patient, from the beginning of the slides, that person walks into your office, you gotta know that you have 2 great options to treat them, but you just gotta be selective about which ones you choose. So, for vascular lasers, I think a kind of an easy gimme is if the patient has a true contraindication to sclerotherapy. So for instance, they have like an anaphylactic reaction to the sclerostin that you're using, and they still have these little veins and they want them treated, you can say, well, rest assured, I have a great option for you. But you gotta be very selective about which vessels you're treating. So, if you have an isolated telangiectasias, you take a step back, there's no reticular veins, the vessels are smaller in caliber, then you can say, okay, this might respond really favorably to the laser. And I have like question mark prone to telangiectatic matting here just because I think it's impossible to just look at a leg and say this person's gonna get telangiectatic matting. It's just, you can't predict that. And not to mention it's a rare side effect that typically just goes away with time. But if someone had sclerotherapy in the past and they got telangiectatic matting and they're all distressed about it and they still want their vessels treated, you can say, oh, well, I have this option that's not gonna cause that side effect. And for sclerotherapy, I think the biggest and most important thing is if you take a step back, there's an extensive feeding network, there's reticular veins all over, sclerotherapy is frankly just gonna give you a better, more thorough treatment. Of course, if there's a large number of vessels, I think sclerotherapy is a more efficient treatment. Taking a tiny little spot size and marching all up and down the leg, I think is a little bit unreasonable in our busy clinics. And I have darker skin phenotypes on here because yes, sclerotherapy can cause PIH. I've seen it, I've caused it, but at the end of the day, I think that PIH is gonna be a little less noticeable, especially if you're using KTP or PDL and you cause that hypopigmentation that takes a year plus to resolve. It's gonna be a little less noticeable than that. So again, you gotta counsel your patients accordingly, but know that you have 2 great treatment options. And that is it. Thank you for your time. This is my email and my social media, so please feel free to reach out for questions.